Welcome to Nursing Life 101, the most important nursing class you never got to take in nursing school. We will be traversing different objectives like interviewing, what to do in nursing school, boundaries, burnout, and so much more. If this interests you, I hope you are taking good notes because class is now in session.
Hello, and welcome to Nursing Life 101. We're so excited to have you here with us as we dive into the world of nursing, sharing our experiences, insights, and a little bit of fun along the way. I'm Colby, and I couldn't be happier to introduce my co-host.
Hey guys, it's Christopher. Together we'll be bringing you real stories, practical tips, and discussions about all things nursing. Whether you're a fellow nurse or just curious about the life behind the scrubs, we're thrilled to have you join us.
So the topic today is conflict resolution.
And this kind of delves a little bit into what's kind of pertinent today with some interesting stories about patients attacking nurses a little bit. It's not as in-depth as it will be. That'll be a different topic for a different day. But it
is kind of like a hot topic that is being talked about quite a bit right now. I see it on social media every day. There's like a big movement in just making it more well known, the treatment that nurses face on a shift-to-shift basis every day.
Yeah, and it's interesting because you interact, it's very much in terms of customer experience and customer service as a restaurant because, I mean, yes, it's different because they're paying for a service, they're paying for a food, and it's not necessarily their health, but you have to be mindful of like how you interact with a patient because of this whole patient experience, and then that also builds into Medicaid and Medicare and how the hospital gets reimbursed. But people are mean and can be mean.
Yes.
And it can be even worse because they're sick. Now, granted, they're probably being a jerk and have always been a jerk, but even when...
It doesn't change the fact that when someone's acting a certain way, it doesn't change the fact that they need medical care.
Right.
And ultimately, that's what we're there to provide.
Yeah. And so I guess, that comes up with the question of, like, when a patient doesn't like you, how much do you take? Like, when's your breaking point?
I mean, I think every nurse has the right to feel safe in an environment. So the second that if it's immediately that person feels unsafe, you can take absolutely nothing and be like, nope, I'm not doing this today. I'm going to get a reassignment. And I totally support that. And I've, as charge nurse, have made quick assignment changes when needed. And just, you have to explain to people what's going on. But I mean, that's just part of the job. Unfortunately, I think probably every single person has faced something at the very least sketchy, if not actually scary, that works in healthcare. And so everybody's understanding when something like that pops up. But outside of like your feeling of safe being threatened, I mean, I think you have to always remain professional and remind yourself that you're there to perform a job. But at some point, like, again, even if you don't feel like your safety is being threatened, you can just say, I can't do this anymore. Like, and I have also done that personally and or been on the other side again as charge nurse and remade an assignment. Everybody is individual. And I don't think that like my point of break of telling myself, okay, I can no longer care for this patient because their treatment of me is going to like diminish my ability to care for them. Mm-hmm. So I know when to walk out. But
I mean, I get that and I do understand, but like there's a point where we have to be a little bit tough-skinned. I mean, you can't legitimately, I've been called the N-word. I've been called all kinds of words under the sun that was derogatory to me being a Black male.
Mhm.
And now, granted, I probably shouldn't have taken it, and I should have changed my assignment. That, like, I should have said something. But I, one, know who I am, and I'm very confident in who I am. And them saying something is not going to change how I deliver my care. But there are points where even something as simple as like, you're slow, like,
Yeah.
people have allowed themselves to not have as tough of a skin because people are more willing to change an assignment. And I'm not saying you as a charge nurse was doing the wrong thing. I just feel like them just doing a simple, like, you're taking forever today. Or, like, people, and I don't know, maybe you haven't had that happen. I've seen people try to change an assignment because it was something as simple as that.
That's silly. Honestly, I it's silly, but it does happen now that I'm thinking about it. Like, I've definitely seen people try to, like, tiptoe it that way, be like, they don't want me to be their nurse today.
Right.
And I'm like, you're still their nurse today. Like, there's sometimes people, like, if it's a patient that's, like, a particularly difficult patient and where we, we'll rotate, we'll, like, quote unquote rotate this
Yeah,
patient.
they're
So, like,
difficult.
nobody has to take care of them more than just one shift.
Yeah.
But I definitely have had nursing staff go into a room and, like, purposely say something that's, like, just a little off to piss off the patient. And then
Just enough.
yeah. And then be like, oh, they don't want me to be their nurse anymore today. And I'm like, come on, man, you provoked that.
Right.
But I've also seen people not necessarily provoke it, but the patient just is already starting as soon as they open up their eyeballs and start saying stuff like that. And I'm like, no, like, I'm not redoing the assignment. So, and sometimes the patients will be like, I want a different nurse as soon as they open their eyes.
Right.
And you have to set boundaries with them.
You do.
I was like, you don't even know this person. You haven't even given them a chance. We're not going to do this today. Like, you can't fire every nurse that comes into your room. You're here because you need medical. Like, you have to remind the patient, like, one, why they're here and what our job is and that we are doing our job. And that's annoying and unfortunate that we have to.
Yeah.
But that's reality.
It is. And that's why I was like, how much do you take it? Like, I know you also have gone through a very tough situation and have toughened your skin and have allowed yourself probably to go a little further than what you probably should have.
Yeah, I would say in the past, definitely, but also because of my role in as the SAVE champion, which is situational awareness of violent events, and basically you're just kind of like the safety champion. It's like, going to all the meetings at the hospitals, changing policies and all this stuff. It's just like bringing it back to the floor. That's basically what the champion role is. And then we have we have different, like, subjects, I guess. But anyways, that was a tangent, but in my role as the SAVE champion, I think we're trying really hard as a health system to change the narrative of nursing just kind of like taking abuse from patients.
Right.
And just kind of the old mentality of it's just part of the job. So I am actively trying to kind of change people's thoughts on that. And, like, yeah, I've been a nurse for 10 plus years. And yes, I've had a urinal full of urine thrown at me. I've been spit on. I have been cussed out.
Right.
My life has been threatened.
Right.
Patients have lunged at me. I've been hit. Like, and at one point it is what it is. But we have rights as staff.
Yeah.
And so I just like for people to be educated on that and, like, what the hospital will do to support us if something was to happen, what laws are there to protect us, that kind of stuff.
Yeah. And, it's definitely a difficult line to cross. And I appreciate the SAVE committee because it does. We as staff members have rights and we as humans have rights. Like, I mean, you just, you can't go threatening somebody.
Yeah. You can't walk into a grocery store and tell somebody that, I don't even know, just something crazy. I'll use an example of something that actually happened last week on our unit. I'll say what happened, but put it in the case of going to the grocery store.
Oh, interesting. Okay.
Mm-hmm. You can't go to the grocery store and grab the cashier and pull her into you and kiss her neck and say, hurry up and come back so I can do quote unquote oral sex on you later.
No.
Yeah. And the nurse that got told that did nothing to provoke it, was
that is
only being
gross.
professional, and this patient was
That's
to do that is disgusting.
Yeah.
Yeah. If you can't go to the grocery store and do something like that, what makes you think you can grab a nurse and do that?
That is gross.
So disgusting.
So gross.
Yeah. Absolutely repulsive.
Like, were they okay?
Yeah, luckily, but like in the way that I would have highly considered pressing charges.
Oh, I would have probably just punched them. And
Yeah.
I mean,
Yeah.
I don't like being touched in the first place. So,
Yeah.
like,
just absolutely disgusting.
that, yeah. Wow. I can't believe people. So, like, how do you set boundaries? Like, there's a point where we as nurses, and all of you know, there's something called the daisy, and those things are somewhat coveted as a nursing like achievement. You were able to get this daisy, and we're seen as like a nurse that does above and beyond just the normal call. So, like, how do you set those boundaries before, like, to get the daisy, but also not lose your sanity? Like, we said this in the first episode or second episode. You've never gotten one.
Oh, I've gotten one since then.
Oh,
my first daisy. Boundaries setting, and like when do you give up the dream of the daisy,
right?
And just like, I need to get through this shift. Yeah. I mean, let's be honest, the patients that are giving us the hardest times, they weren't going to write us a daisy regardless. But let's be really honest. But no, I mean, it's most important to set boundaries like immediately. And I'll give you another example. Like, we had this old man, he was a little bit confused, and honestly, he might have just been like milking the could not hear thing, like refused to wear hearing aids and just acted confused.
Selective amnesia. Selective deafness.
Yeah, selective. But he did it to a few different staff members, and then I went in and I, checked on him. How are you doing? How are you feeling? Having any pain?
Yep.
And he said, no, I'm good. Okay, you look like you're enjoying breakfast. Is there anything else I can do for you? And he was like, well, and then grabbed my hand and kind of pulled me a little bit and said, you can get in this bed with me.
Oh, no.
And I was like, sir, I met your wife. What do you think she would say if I told her what you just told me and 3 other staff members today? I don't think she'd be very happy. And he said, oh, yeah, you're right. So sometimes a little shame is not frowned upon. You should just go ahead and shame them. I mean, but read the room, because obviously, like, somebody else isn't going to respond to that. But, like, there are little ways that make it less awkward or make the person feel like, I mean, not to say that you shouldn't make them feel this way, but, like, you can say things that wouldn't make them feel, like, accused of doing something bad, because sometimes that's going to further like snowball into a more difficult, or it will continue to get worse,
right,
if you say the wrong thing to someone. So like a confused-ish old man who thinks he's being kind of cute, like, you can kind of let me be real cute right back. I'm going to tell your wife on you. And it's okay. But then there's some people where you do have to have like a more direct conversation.
Right. Yeah. And it all depends on the person, right? Like if it's a person that's an old man, he probably is very much a old-timey person. So by this time, if they're still married, divorce is probably not a thing. And saying something to bring up that he is married is going to bring shame onto him and his name, right? But if it's just a 20-year-old who, that had just got married and is thinking about getting a divorce already, like, he doesn't care if you're going to tell his wife.
Yeah. So
you say, sir, this is not how you're going to talk to me. Mm-hmm. We are going to be here for your as a professional, taking care of you and making sure that you are in a healthy state. And you being sexually aggressive is not
appropriate.
Appropriate.
Shut it down.
Right. And that's okay. And you didn't say anything out of the way. You didn't say any slander. You
just put it out
just
there.
put it out there. There's a inspirational speaker / author who her name is Brené Brown, and my manager absolutely loves.
Yeah.
Okay. So both Colby and my manager love Brené Brown, and one of her sayings is clear as kind.
Clear is kind. Yes, it is.
And so being very clear and telling people, because really and truly, we as nurses, and I think we've said this before, we have to build trust with our patients.
Mm-hmm.
And building trust with your patients means that you are going to tell them how it is in the best way possible that you can tell it. And the best way possible is for you to be clear. So you're going to set that boundary and say, this is not how I'm going to be handled. And I'm going to be professional and ensure that you get the best care that you can. But you saying this is not allowing me to do that.
Right.
And as you're clear to them, that honestly, it might at first seem like it's cutting a bridge or tearing down a bridge, but they're going to be like, oh, you know what? I'm sure they're probably going to actually take care of me because they took guts to say, stop that.
Yeah, a lot of times you'll find like after you kind of just like are very straightforward, it's almost like, oh, okay, I'll respect them now.
Yeah.
It really and this is so annoying. Like, we shouldn't even have to have these conversations.
No.
You'd think people would just be normal human beings. But apparently the normal is that they're all weird. Like, my normal is not the majority's.
No.
Is what we learned.
And it's interesting because there are so many nurses that truly want a daisy.
Mm-hmm.
They truly want a daisy. And those patients that are sexually aggressive or sexually inappropriate or just straight nasty are not going to be the ones that write you a daisy more than likely. So, just forget about that. Really focus and put your energy in the ones that are nice and probably will write you a good review. There's importance in that. When we talked about this a little bit before, is like changing an assignment. Maybe not necessarily when do you ask for a new assignment, but like how do you go about asking for a new assignment? And I guess think of it as a Clin 1 who is probably new and is kind of timid and like.
Mm-hmm. Oh my gosh, I'm picturing like a Clin 1 just like not asking and like praying that somebody helps them, like,
and goes home and like
it's like, I had the worst day ever. Right. I need to quit this job. Right. I'm out.
Which is not what we want.
No. I hope that as a new grad nurse or graduate nurse or Clin 1, whatever they call you at your facility, like I hope that you have some like faith and trust in your leadership.
Mm.
I mean, literally, oof. Yeah. Because really, I mean, if you were just getting off orientation and you got like a shit assignment and you like somebody is just cussing you up and down and you're frozen, like I'm seeing it, like you're frozen, you don't know what to do. I hope somebody's watching you. Like, I hope someone's looking and not like watching you like, oh, we're watching you get yelled at. I mean, like,
I always feel like somebody's watching
I hope
me.
someone is like mama bearing you or papa bearing you, like keeping an eye out and watching you throughout your day, checking in, so that if that way you either one felt comfortable enough to come tell that person, whether it's a charge nurse or another nurse that's just working, or your manager or your assistant nurse manager, like I hope that you have at least one person every shift that you are like, this person's looking out for me, like that you could tell. And at the very least that your charge nurse is actually looking out for you, because that's a part of your job as charge nurse is to watch watch everybody, but keep an extra special eye on the new grads that are off orientation and now flown the coop and are out there, floating, like trying to hang on. Like
they're doggy paddling
out there, and you just need to make sure you can throw them a bone if they need one. So it's like I definitely keep a close eye on my my new grad nurses once they're off orientation. And if I work, my unit split to 2 units. We have a big unit and a 12-bed unit. And this isn't just go for my new grad nurses. Like, I have walked in on rooms, my hearing is great. Like, if I hear a voice raised, you better bet I'm doing a drive-by at least. Like, are you handling the situation? Do you need backup? Because I'm here and I'll walk in.
Well, yeah. And, the interesting thing is that I have worked under you, 1, as charge, and then 2, I've seen how you just are interacting with other patients and coworkers, and it really is interesting how quickly you're able to analyze a situation and be like, yeah, I'm stepping in.
Mm-hmm.
Like, I'm not doing that. Your unit, like I said, once again, my unit is just so much bigger.
Yeah, no, yours is geographically massive.
Right.
Yeah.
And so it is so difficult to have our church nurses be as attuned because there's no way your ears can hear that far.
Yeah.
But there was a time where one of our new Clin ones came up and was like, after it was like a day or two, and I just happened to hear it from someone else. And she came into my office and was like, talking. And I was like, hey, I heard patient so-and-so was really rude to you.
Mm-hmm.
And she was like, yeah. And she tells me the story. I was like, I am so sorry that you didn't feel comfortable enough to come and talk, to tell me that.
Mm-hmm.
But next time, do not allow that to happen.
Mm-hmm.
And please come and get me. I'll roll up.
Mm-hmm.
And because that's not appropriate, and that is not fair to you. That's ridiculous.
Yeah.
And, I really did. I felt really, really sad that I did not, I failed her.
Yeah, you do. You feel, I can definitely imagine that. Because, where your heart's at is wanting to protect everybody.
Right.
And then you feel like that person, not that you didn't know about it in time, so you couldn't, but that person wasn't protected by someone.
Right.
That kills you. You're like, this is crazy. That's bullshit. You should never had to go through that. I'm so sorry.
You really shouldn't.
Yeah.
And we were really focusing on Clin 1s, but Clin 2s, 3s, 4s, experienced nurses, however you want to call yourself.
Everybody experiences the abuse.
Right.
Yeah.
And you shouldn't have to take it.
Yeah.
Even if you're the veteran on the floor, you are looked up to, but you should still have, you might be the charge nurse, but you should be willing to talk to your assistant nurse manager or your manager, director, somebody,
Mm-hmm.
because that is not something that you should be experiencing or putting up with. The occasional name calling, if it's it's hard to say name calling is mild, but I guess it really does boil back to what you said at the beginning, Colby. If you feel like your safety is in jeopardy,
Mm-hmm.
you should not. That's the line.
Yeah.
If your jeopardy is in danger, if your safety is in danger, then
pull the plug.
Pull the cord.
Yeah, that's it.
That's it. That's all you have to really focus on. If you do not feel safe, or if you don't feel like you can give safe care.
Yes.
Because that can be different.
I was just going to say that.
That can be different.
Yeah, if the treatment on you is making you feel like, you know what, I don't think I can deliver optimal care to this patient at this point because I'm so upset or I'm so angry or I'm so hurt, I'm going to step away.
Right.
Yeah, we're going to have to, I'm done. And unfortunately, you will experience that if you don't know what we're talking about. It's going to happen. You can be the best nurse in the world, but if somebody does or says something to you, you're going to hit your wall and you're going to know when it is. And you're going to be like, you know what? I physically can't go back into this room again.
Yeah. I'm one of those people that internalizes a lot of stuff and just lets it sit and fester. I've gotten a lot better, but when I was younger, I could just remember, and my dad, I'm sure, remembers this story, and if he's listening, he probably will kind of chuckle. But I had just gotten over a labral repair. I had just finished that, and it was kind of rehabbing my arm. And my dad and I played baseball, and so we were playing baseball and doing all these things, and I was rehabbing in the hallway of our of our house, and I'm rehabbing, and not doing things right. And Dad was like, take a break, and I was so pissed, and like everything up until then had just really boiled, and I went to go hit my dad, and I was like, "That's not the right thing."
Thought better.
And so I punched the wall and punched a hole in the wall.
Oh no, that wasn't good either.
Yeah, I was like, well, had to patch it up.
Learn a
Whole
lesson.
thing, lesson learned.
But let that be your lesson listening to this today, and not let yourself get to a point where you explode like that, because then you're breaking your professionalism. You're not there delivering the care that your job is. The patient has now won.
Right.
Basically, I hate to say it like this, but that really is what it's like. It's like they're like, "Oh, I won. You are a terrible person. You're scaring me," even though you were brought to the edge by this person.
Right.
It's like you have to recognize when you're getting to a point where that's it. We're not doing anything else here.
Yeah, and it really also is finding, and we'll talk about this later too, is finding a way to mentally be able to heal yourself and make sure you're healthy in spite of having all these terrible things going on, codes, people dying, abuse by patients, coworkers that get on your nerves. Like, all those things build up, and you can't allow it to just fester. You have to find that outlet in a very healthy way and do things outside of work, even in your 30-minute break, because I'm going to emphasize that again. You need your 30-minute lunch break, because that needs to be a time where you decompress for that first half of your day. And because who knows, you might have 3 patients that code on you in one day, and you have to still work.
Yeah. You have to keep going.
And you can't break down. Nursing is a strong profession.
Meaning that you have to be strong.
Right.
Okay, so is getting a new assignment mean you're a failure?
Absolutely. No.
Absolutely not. Let me make that not part a little bit louder. Absolutely not. I mean, honestly, if anything, it means that you are in tune with yourself. And
right.
One, like, okay, I've got to step away from this. You should be proud of yourself to know, like, what your boundary is, because it's hard to find, especially as a new grad. Like, I've took so much stuff that I shouldn't have, and I've seen coworkers take way more than what they should have. And seen, leadership step in and be like, we're not doing, like, you don't have to do this anymore. We'll figure it out. Like, we'll reassign.
Yeah. And really and truly, like, it's not a failure on your part, and it's okay to spread the love. Like, it's not love, but, like, in terms of, like, if you can only take care of that person for one shift, if you genuinely know tomorrow will be the shift that breaks you, go ahead and tell the charge nurse, if you can, just remove me from this assignment. If you want a whole completely new assignment, which Colby talked about a couple of podcast episodes ago. But also, if you're just like, I can't have room 5 anymore, like, that's okay. That's totally fine.
Yeah, we do it all the time. There's always notes at the charge desk that says room 5, no, blank, 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 right. Like, all these names, because we're rotating them. Like, it's just, we can only do one day. Otherwise, we're going to quit this job kind of situation.
And there are one and done patients, is what we call them. One and done.
One and done.
One and done. That's okay. And to those that make that one and done 2 or 3 days, more power to you.
Yeah.
But you don't have to. Especially if it's known that this patient is difficult.
Yeah, and that's the mentality in every hospital that I've ever worked at. It's like, it's the mentality and the reality of life is that there's always going to be difficult people, whether that's someone you're passing by on the street or the patient you're assigned to take care of for the day. And I think it really like helps to when you realize that you don't feel that like guilt for, oh, I can't take care of this patient. Does that mean I want everyone else to suffer? No, that's not what's going on. Like, we are all of the same same mind. We all understand what that person's going through, and we just expect it. And sometimes we make changes on the fly. That's healthcare.
It's true. And, in order to keep you safe, like, it's okay to document some of these things. I know certain electronic health records allow you to put in notes and then kind of hide it from patients to make sure that they don't see it in their personal, like, mobile record where they can see their medical records on their phone. And it's okay to put those notes in and being like, patient was verbally aggressive, stating blank, blank, and blank.
Yeah, it's always good to quote.
Right.
Because that's what they said.
Right. And if it's curse words, put those explicits in there. Like, it's okay.
I do.
Yeah.
I'm like, oh, that's what you want to say to me. Okay.
And our personal electronic health record has behavioral flags, and it's able to really emphasize what this patient is doing that's inappropriate. And in a court of law, if something was to happen, if you were to press charges on someone, you need that information there, because you take care of so many patients. You might not get that until, like, court date until months after.
Yeah. Documentation is super important. You need to create a paper trail when these adverse behaviors start developing, and what you did to try and mitigate it, education that you provided, medical team notifications of the behavior. Like, these are it's all important to prove that, like, if their behavior is adversely going with their care plan, and they don't want to participate in their care plan, and then they're doing, you know what I'm saying?
I know this story. Okay.
Oh, well, this story is for every single patient.
Oh, okay. Never mind.
But and when I say every single patient, like, when we're talking about documentation, this is what I mean. Like, most of the time, the difficult behaviors that we're running into are impeding care that they're there for.
All right, it's time for this episode's Spotlight Case, where we break down real-life nursing scenarios that left a lasting impact. Some cases challenge us, some teach us lessons the hard way, and some, well, they remind us why we love or question this profession.
And today's case is definitely one to remember. Picture this. You're mid-shift, everything seems somewhat under control, and then out of nowhere, things take a turn fast.
So let's set the stage for each of us, and here's what happened.
Okay. Well, literally, quite like I just said, everything was fine, and then we're going awry real quick. We have had this particular patient quite a few times on our unit, which often you will find when dealing with a patient who is admitted with infectious endocarditis related to IV drug use. Unfortunately, this patient came back again for I don't know, maybe the third or fourth time this past year, with worsening infection. I don't think that they ever truly cleared it. As you can imagine, a patient with a history of IV drug use or abuse can have pretty difficult personality traits to deal with at times. The patient had been with us probably for about 4 weeks and intermittently manipulating team members, medical team members, and nursing staff into getting what they want. Often, for an example, would start screaming and yelling at staff and refusing to participate in the care plan. He refused medications, telemetry monitoring, vital signs. The patient was a diabetic, refused glucose checks, insulin, ended up on an insulin drip because
course.
their sugars got so bad.
Yes.
So fast forward. That's to set the scene.
Ooh.
Yeah, it's a lot every day. Doing the same thing over again, arguing and trying to educate and convince, and
It feels like it's not worth it.
it feels like it's not worth it every day.
Yeah.
It all came to a head after I had been off for a few days, and me and this patient, we had like he had a little bit of respect for me. I'd been in the room multiple times when they were starting to melt down and kind of like got us back on track over the last few weeks. I'd been off for a couple of days. Apparently the day before, things got pretty heated. He was out in the hallway, raising voice, screaming, cursing language. And I don't even remember what about. It could have been anything, truly. And it was usually like the smallest things. And then in order to get him to calm down, staff was just going downstairs to the cafeteria to get him a meal that he would prefer, like sushi or...
Which came out of the unit budget.
Yes, it comes out of the unit budget. It's not like the hospital like pays for it.
Right.
Or so he would do things like
We're
this.
not that fancy.
Yeah, we are not that fancy. He would do things like that, like refuse antibiotics until he got the sushi that he wanted, for example. And it would be a knockout scene.
Oh, yeah.
So the day I come in, Oscar winning scene every time. The day I come in, the nurse that was assigned, I was in charge, the nurse that was assigned to take care of him went in to give him his medications, to which he immediately replied, "I'm not taking any of it except for the Suboxone and gabapentin, or anything that'll treat my pain." Refused the antibiotic, refused the antifungal, refused all these important medications that he needs to take for his blood pressure and all this stuff. And the nurse took all the medications and said, "I'll be back when you're ready to take everything."
Which is a great boundary to set.
Yes. And she was walking out of the room, prepared to go send the doctor a message to let them know that the patient does not want to take the medications except for the two medications that he said that treat pain. And he followed her out of the room.
Oh, Lord.
Aggressively starts screaming, calling her offensive names.
Of course.
Saying all kinds of crazy stuff that she's like withholding his meds because he just wanted the pain meds and didn't want the antibiotics and all that stuff that he had been refusing for more than 24 hours documented. The nurses just say, charted refused, let the doctors know. The doctors were aware. Like, everybody's been letting this man
slide,
get away with all of this for multiple days in a row. I was sitting there when he comes out of the room and I said his name and I told him, "You need to go back to the room." To which he was then redirected his anger and screaming towards myself. And I was not the one.
No.
But I did remain professional. I told the patient again to go back to their room. They refused. I picked up the phone and I dialed our emergency number, which got our operator to send a behavioral emergency response team. I also asked for the police. The patient then realized that I wasn't joking around and went back to their room, but was still screaming at us from the doorway. When the police came, so did the doctors, our hospital security, our nursing supervisor, our assistant nurse manager, and myself as charge. We all went into the room. The patient seemed to calm down, said that then became agreeable to take all of their medications. And so I go in there. I told the nurse, "You don't have to go back in there. We're going to figure this out." And we told with the medical team, since this has been greater than 24 hours, just flat out refusing the medication that he's been admitted and being treated for. Get him on an oral antibiotic and discharge him.
Right.
So I said, "Great, I'll take care of him until he walks out the door." I go in, I get all of his medications, I give him all of the orals, I go to hook him up to his IV, and I had to go get the scanner from across the room. And right as I'm scanning everything, he goes, "Can I go to the bathroom?" And I was like, "No, I'm going to finish doing your medications. You can bring this IV pole into the bathroom with you. So you're going to wait until I'm done."
Right.
So I hook him up to the antibiotic. So, because of how sudden it was, and it was right after I had given him his Suboxone, the nursing supervisor was also in the room with security and in the police. And she looked into the bathroom because she was like, that was kind of suspicious. And in the bathroom, she went in with security observing, was a box, like a to-go food box. And so she opened it up and lifted up the washcloth. And in the to-go box was white pills in a medicine cup, a cut straw, and a used saline syringe that was dirty. So it was very apparent that the patient was crushing some sort of medication. I don't know if it was something that that he had been getting at the hospital, or if it was something that he had when he came in, or was it brought in? That's all. We're not sure, but it was very clear that they were using it based off with the syringe and the straw.
Right.
So I got him all hooked up. He goes to walk into the bathroom, and the nursing supervisor asked him if he had anything else in there that they need to be aware of. And he got very activated.
Of course he did.
Because, his secret stash was found. And then was screaming all over again. We all exited the room for our safety at that time.
Right.
But then that did prompt, like, per our health system protocol, that his whole room needed to be searched because there could be other paraphernalia or drugs in there.
Right.
When the attending came to the floor, because we work in a teaching hospital, so we work more closely with the residents, and then, they go up their chain of command. The attending came onto the floor and was like, I'll tell you what we're not going to do today.
Not having this.
We're not doing this. So he's going to go in. I'm going to tell him what the plan is. And if he disagrees, then he can leave. As you can imagine, the patient did not consent to the search and did not want to consent to completing his antibiotic and participating in his care. And so the doctor said, that's fine. You will be discharged then.
Did he sign out AMA?
So he refused to sign out AMA, which happens a lot of times. But I learned that day, after 10 plus years, that there's something at our health system called an administrative discharge. And it's like when you have multiple documented accounts of behavior like this, physical and verbal abuse to staff, and they don't want to participate in getting better and getting the treatment that they require, the hospital attending can discharge them from the hospital.
I wonder if that's something that's done in all hospitals, because I feel like if they don't have that, there's a problem. It should be something that all hospitals should
use.
Have.
Absolutely. And I think, sorry, go ahead.
No. And the fact that you have been here for 10 plus years.
It was the first time I've ever seen it.
Right.
I was like, what?
That's a problem.
Amazing.
No. And, I also had never heard of it until and I was like, oh my goodness.
Yeah. I was like, I'm keeping that in my back pocket. I feel like in this day and age, physicians, LIPs, they're so scared of getting sued, which rightfully so. I mean, that's a word. That's a nightmare.
Mm-hmm.
But I think it's almost to their detriment that they keep patients or beg them not to leave because of the fear.
Right.
And it's like these patients, there's so many documented accounts of them not wanting to participate in their care plan. Why are we begging them to stay? It's a waste of my time. It's a waste of your time. It's a waste of their time. And there's 100 patients waiting for a bed in the ED right now. So what are we doing here? That's crazy.
Get them out.
Get them out.
Yeah. And it is funny because we do have so many people that are sick and are willing to have their care being given to them, where we cater to these aggressive, combative people, and it's like, nah.
Yeah.
If you need money, if the hospital needs money, there are plenty of people that can give it to you.
Yeah.
So my interesting case is I was charged also. So this was when I was on the floor, and I was just a wee charge nurse. I had just started, like, literally, I think it was literally my first shift off of orientation as charge. It was either my first or second. It was within the first week. And I had a newer nurse who was taking care of a patient who had just had rejection of their organ, and they were going on and doing steroids, pulse steroids, and rabbit or anti-thymocyte globulin. And they were going through and getting the steroids, but they also had diabetes, and so they were on a glucometer or insulin drip.
Mm.
And so I'm going in, and I have a lot of the times I either wear my hair in cornrows or box braids.
Mhm.
And I was wearing my hair in box braids at the time. And so I had beads to kind of help lay and bring the hair down and make sure it didn't curl up. And it makes noise, kind of like jingle.
Like
Yeah, that.
that's my nails.
That. And so I went in and talked to this patient, was like, hey, how are you? You have this insulin drip, and I was changing it. So I was like telling the patient, excuse me, what I was doing and why I was doing it. And I was like, oh yeah, you're going to be almost off of it in like 2 hours because we had just given the NPH and blah, 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 blah. And I went ahead and did leadership rounds. It was like, how are you doing? How's your care? They were like, oh, it's great, blah, 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 blah. And I was like, okay, cool. And so I leave,
Yeah.
and walk out and continue my leadership rounds on the rest of the patients. And I come back out, and my I don't think they were a Clin 2 yet. So my Clin 1 was like, Christopher. And I was like, yeah, what's up? And they were like, patient in room 25. I can't remember which room it was. I can't find them. And I'm like, what do you mean you can't find them? And
What? They ran away.
the nurse was like, I have no clue. I checked the bathroom. Their stuff is gone. They're not in the bathroom outside of the unit. I had my PCT run down and like look at the cafeteria to make sure they didn't just like wander down to the cafeteria. And I was like, oh my God, are you kidding me? And I had gotten to the point where I was like, oh my gosh, so what do I do? And I luckily had a experienced charge nurse. This was night shift, by the way. I had an experienced charge nurse that was there, and I was like, what do I do? And we had to walk through this whole process, and I intercommed the entire hospital to make sure they were like not around the hospital. And then we're starting to call the patient. We're like, call the patient. No answer. None whatsoever. So much so that they started to like, ignore the calls.
Oh, they were just sending you straight to voicemail.
Straight to voicemail.
Wait, did they take their IV pole with them, or did they take?
So they had just gotten off of the.
Okay.
Yeah, they had just gotten off the insulin drip because of it was like right when he had finished the insulin drip.
Okay.
And so finally we were like, we've got to do a well check.
Oh, God.
I mean, like, we've got to.
Yeah.
Because they still have the IV in.
Yeah.
They still have an IV.
Yeah.
They don't have the drip, but they have an IV in.
Mm-hmm.
And so they go to this person's house, which is over an hour away.
Oh, gosh. Okay.
And the patient's there.
They were like, bye.
And I'm like, long story short, this patient said, I quote, Christopher, the charge nurse threatened me and I didn't feel safe, so I left. And I'm like, there goes my job.
Oh my gosh. That's crazy.
I'm like, I am done.
That's so crazy.
As you can probably
What
deduce.
a dirty little liar.
Oh my God, it was awful. I was petrified.
Yeah.
That I was going to lose my job.
Yes.
Like, what? Luckily, this person had documented accounts of.
There you go.
I know,
documentation.
Right? Steroid-induced psychosis.
Okay.
And so they were able to deduce that it was the steroids because we were giving them such huge amounts. And that
How did they get home, though? Did they drive themselves?
They drove themselves.
Oh, Lord.
I know.
Yikes. So did they call an Uber?
No, because they came in for rejection treatment. So they drove themselves here.
Lord, that is so crazy.
Wild. This made no...
So did they get brought back by the police?
They didn't. They actually came... They went to their local hospital because there was a local hospital there.
Uh-huh.
And then from there, they got shipped to us, which we no longer had a bed for them.
Oh, no.
Because it was, I mean, within...
someone leaves, there's a person right there in line for the next one.
It's a protocol that we just we give the bed away.
Mm-hmm.
And so, I'm sorry. That's just a free little story there.
I mean, it does tie into like unfortunately, there was like a true medical cause for them to have this thought or idea.
Right.
But it does tie into like accusing you of something that's not true, which you'll run into.
I was like, oh my gosh. And I was terrified. But obviously I was okay because I'm now the...
There were no marks on his background check after that.
I still have my license. I'm now the assistant nurse manager. I think I'm fine now. But
no red marks on the resume.
Like, wow.
That's so crazy.
It's wild. All right. So that wraps up the segment break. I'm not going to give you another case. That was the one I was banking on.
We'll stick to it.
Yeah. So, to kind of wrap this up, interestingly enough, patients aren't the only ones that really test your patience.
Patients aren't the only one that tests your patience. Sometimes your problem could be with your coworker.
Right. So when a coworker doesn't like you, what do you do? How do you handle it?
Me personally, I just avoid them. And I think honestly that's good advice across the board. If you know someone doesn't like you for whatever the reason is, just avoid them whenever possible. And maybe someone else would say something different, like you should try and figure out why. But honestly, as someone who doesn't like certain people, I avoid them. So I appreciate it if they know that I don't like them, that they avoid me. But that's not to say if they need help, I'm gonna help them.
Right.
That's your job. You're there for your job. You're not there for personal relationships. Sometimes your coworkers become some of your closest friends, but that's not a necessary part of the job.
That's true.
Yeah.
I'm starting to... I told you that I read this book called The 5 Dysfunctions of a Team.
Yeah.
The bottom foundation, or the first dysfunction, is the lack of trust.
Mm-hmm.
And I'm learning and growing, and I'm not perfect with this at all. But something that I'm starting to emphasize is that to be a team, we have to learn to trust each other.
Mm-hmm.
That means that even in the midst of us not liking each other, if we come to you with a corrective or a criticism that is conducive, and what is the actual C word that I'm looking for? Constructive.
Okay.
If I come to you with a constructive criticism, it's not a plight on your character. It's not a attack on your pride. It is for the ultimate goal of delivering excellent patient care.
Mm-hmm.
And so there has to be a lot of trust that you, as the one that's giving the constructive criticism, aren't doing it to just be mean, or just because you think your way is the best way and the highway is the other way. And then you, as the receiver, have to understand that I am going to receive this constructive criticism and attempt to adjust because I know you're doing it for the betterment of the patient care that I'm delivering.
Yes.
And so if there is if there's a coworker that doesn't like you, you still are able to give that constructive criticism. Yes, you might have to stay away from them. You might have to, but if you see something that they're doing that ultimately is not excellent patient care, you have a duty as a teammate
Yes, you have to step in.
and say something. And it's not easy. Like I said, I am nowhere near perfect. I just had a conversation, and I'm the assistant nurse manager. I just had a conversation with one of our teammates yesterday about something that was brought up to me, and I'm like, I've got to deliver this feedback, and it's not easy. I don't like it.
Yeah, they're
awkward, and you feel bad because you're like, I know you're a good person, but it has to be, it still has to be delivered.
Yeah. I think that was a way more professional way to give an answer than me when I just said avoid them. Oh,
Which is
Lord.
interesting because you're one to not avoid people. Like you'll call people out on things.
Oh, yeah. I mean, when it comes to patient safety and care, I'm going to call someone out if something needs to be addressed. I think I was taking it more of like a personal relationship approach, which was when I was saying like avoid them. Like you don't have to like sit and giggle with people or try to like figure out why someone doesn't like you because you're there for a job. You're there to take care of a patient.
Yeah, but I think and I somewhat agree with that. I think there's a point where not every family member likes each other, right?
True.
But really and truly, sometimes you spend this time with your coworkers, and it's exponentially more than you do with some of the people you live in the same house with.
Mm-hmm.
And so, like, you've got to find a way to
coexist. Yeah. No, I agree. I think in the sense of, yes, we spend sometimes more time with the people we work with than we do our families or the people that we live with. Yeah, you have to find a way to coexist because if you don't, and we've talked about this in past podcast episodes as well, like what do you do when you have like a disagreement with a coworker and like how should you handle it? You need to get some beef out of the way sometimes, but ultimately you need to remember that it's the patient that you're there for, and so you have to leave it at the door and go to perform your patient care to the best of your ability.
Right.
For the patient.
Really and truly, you've got to this sounds terrible, but you've got to treat your coworker as a patient.
Okay.
Right?
Elaborate on that a little
bit. Ultimately, you don't know this person from Adam. You really don't want to get to know them, but you still have the conversation of, hey, how's your day? Where are you from? You get to build that rapport.
Yeah.
It's not, and
you can be colleagues.
Right.
Yeah.
Well, but that's the thing.
Well, you need to be colleagues.
You need to be, right?
You need to be colleagues. You don't have to be friends.
Right.
So you can be professional with one another and just treat people with general kindness.
Right.
That whole old saying, like, treat people how you would want to be treated.
Golden rule.
That is a golden rule.
Right.
And I think even if you don't like someone, like, you still have to treat them with kindness.
Yeah, and overall, if that happens, and interestingly enough, somebody said something about this the other day. They were like, it was okay. People who have Down syndrome, are the kindest people in the world.
So true.
They're so kind. They're so loving. They're so like non-judgmental. They just are so kind.
Mm-hmm.
If the world had everyone with Down syndrome, there'd be a lot of differences.
Be a lot of happy people.
A lot of happy people. But we can learn from that.
Yeah.
Right?
For sure.
Like these people who have far less abilities than someone who doesn't have Down syndrome are so great role models of just being kind to any and everyone that they meet. And so, I'm using this as an example, but like for real, like you've got to learn how to not be sarcastic, like all the time. Like sarcasm doesn't get you anywhere. It really doesn't. I don't like it. It rubs me the wrong way all the time. But but here's the huge caveat here. I understand when people use it, and I don't take offense to it. I don't like it, and it does rub me the wrong way.
I feel like you just said the opposite. I feel like you just said that you don't like it, but you're like, I don't take offense.
But I don't like it. It's not something I appreciate.
Okay. It's not that. Yeah, it's like it's not that deep. I get it.
It's like, man, you really
it was just
calling
funny.
me out of my.
It's just funny how you ordered it.
I might just take this out.
Sorry.
I'll think about it really quick. But really and truly is what I'm trying to say is that there are things that people do that might not be the same way you would deliver or say things or handle things. And it rubs you the wrong way, but you still can be kind. You still can find a way to understand that person, not befriend them. You don't have to befriend them, but understand them to the point where you're like, that's just Colby.
Yeah.
I mean,
yeah.
That's just Roman, my dog's name. And you just kind of live your life with them. But how do you like avoid retaliation? Like, is there any point where you're like, man, they're actually gonna come at me?
Oh God, I hope it doesn't get that bad.
Well, I think not necessarily. Not like coming at you with a knife.
Not like physical, but like maybe they're like trying to get you fired or something.
Yeah, that, or they're like, oh, did you hear so-and-so did something this way?
Like
we should gang up on it. Or, we shouldn't befriend them.
Okay.
Maybe not.
I think that's like such mean girl mentality.
Well, and this is a very sexist statement, and I will probably edit it out after this. But
that nursing is mostly
female.
Yeah, no, that's true, and that's just a fact. You don't have to edit that out at all. And I do think it's like I'm a woman, so I can say it, but that's the nature of women. Like, it gets catty. Like, I would definitely say that I've witnessed like people be mean to each other for no reason, and and again, I also saw it a lot more when I was younger, and I would feel like sometimes I'd be like involved or like in the middle of situations when I was or my earlier days in nursing, or I was just like younger. I was in my 20s, and I feel like it was the same kind of mentality that like high school or college snooty girls had, and I don't know. And now that I'm older, I observe the younger staff kind of getting catty with each other sometimes, but I think with like wisdom, I'm like, it's none of my business. And I personally maintain professional relationships with everybody that I work with, and I'm not friends outside of work with very many people anymore because of experiences I had when I was in my early 20s in nursing, where like the staff it was like so involved with each other's lives in and out of work, and then when something went awry, it was it muddled with work, and it was too much. So what happened then? I mean, it was pretty like self-contained. I don't think that like management got involved or anything. It didn't affect patient care, I guess, in the experiences that I had. I think the unfortunate thing is like, unless it's affecting patient care, it doesn't really get talked about, right? Like,
yeah,
because you kind of like, I would even like imagine from a manager's standpoint, you're like, it's none of my business. I don't want to get involved. Like, as long as the patients are getting what they need, then I want to look away. And that's maybe not the best way to handle things, but it's probably how I would, unless it was like brought to me.
Yeah, I don't know. I went through the 75 hard made me really go through this like self-developmental management, and I'm learning that management has a huge influence on team culture.
Mhm.
And I do think that there have been changes within my unit that has made team culture a different challenge that both my manager and I are learning to navigate.
Yeah, it's
Ooh,
an
that was
ongoing
hard.
it's an ongoing journey though for everybody. I mean, so in a manager role, like you have to figure out how to deal with these situations. It's just part of your job. I think if again, like if you're on the floor, and we talked about a little bit about this when we talked about our tech nursing aid episode, like if you're having a situation with your coworker and you're getting less help from them than they're giving others, or you feel like you're drowning every shift and nobody's willing to help you, like these are things that you need to speak up.
Right.
You need to tell your leadership that these are your struggles, because if whatever you're doing isn't like getting resolved, whatever's happening to you or whatever you're doing isn't getting resolved, those situations again are just going to trickle down to the patient care, and then the patient's not getting their needs met.
Yeah.
You need to talk to your leadership.
For sure. And ultimately we are here for you, ultimately management is supposed to be there for you.
Mm-hmm.
And there are times where things from upper management or even just the health system in general can allow middle management to get so drowned or muddied in things upper management and health system needs them to do, that we can lose sight of those that we're actually there for, which is you as staff members. I think that's what has been the hardest part for me, is because now that I had stepped back on the floor, I'm like, whoa.
Yeah.
Like there's
that shift to the other side is kind of striking.
Right.
I would also like to say, like we talked, like you mentioned, like you have to have trust in your coworkers in order to have like a good like work balance, relationships, make the team flow, the teamwork. You need to have trust. I would say if you're in a situation where you feel like you don't have trust, and I mean not have trust with any coworker, with anybody in your upper management, in your middle management, HR, human resources, is a great place to reach out to, and that's at every health system or any job. They're gonna have a human resources department, and part of their role is conflict resolution. They hire people specifically in the subject, and they'll help be mediators or just listen to what you have to say to try and resolve and find a solution to whatever's going on. And that, like, your problem might be with your manager, and you feel like you brought something up and there was a situation of you feel is retaliation against you. Human resources is there to step in as like a third non-biased party and look at a situation almost like an ethics consult for a patient, where their role is the ethics of the situation that's going on, and they're there to protect you if that's what you need is protection, or help work to find a plan that's going to help get you back on track with the position if that's what you really want to do, you're passionate about that, and they'll help you walk through, like if you decide you want to leave the position, like they're literally there to your benefit.
All right, class dismissed. That's a wrap for today's session of Nursing Life 101. We hope you found some useful takeaways to bring back to the floor. Remember, nursing is a lifelong learning journey, and we're here with you.
If you want to connect, find us on Twitter at NurseLife101 or on Facebook at NursingLife101. And don't forget to subscribe and share with fellow nurses. Conflict is a part of any job, but especially in nursing.
Remember, how we handle it says a lot about our professionalism. Until next time, keep learning, stay resilient, and make a difference.